Hi, and welcome to What's Next on the Roadmap, Finding Primary Care. I'm Tricia Hernandez, Director of Community Engagement with the Leukemia Lymphoma Society, and I'm here with a panel of experts to discuss all things primary care, especially when transitioning from oncology care to primary care. I'm going to ask each of our panelists to introduce themselves, so I'll start with Donna Bell.
Hello, I'm Donna Bell. I am a nurse practitioner at the University of Texas MD Anderson in the AYA survivorship program.
Welcome, Donna. Thanks for joining us. Dr. Sam Siegel.
Hi, I'm Sam Siegel. I'm an onco-PCP and survivorship clinician at Kaiser Permanente, San Francisco, and I'm a relapse refractory Hodgkin lymphoma thriver.
Thanks for joining us. And Abby Singh.
Hi, I'm Abby Singh. I'm the Director of Patient Content in the Nutrition Education Services Center at the Leukemia Lymphoma Society. I'm also a melanoma survivor, and I was diagnosed as a young adult.
Thanks, Abby. And Elissa Baldwin.
My name is Elissa Baldwin. I'm the Director of National Patient Education at the Leukemia Lymphoma Society, and I'm also an acute myeloid leukemia survivor, and I was diagnosed as a young adult.
Thanks, Elissa. So let's get started. Sam, why is it important to consider primary care and transitions to it from the date of diagnosis?
Wow, I love this question. I think when you have a primary care clinician involved from the date of diagnosis and the relationship is longitudinal over time, then it lessens some of the stress of having to transition back to primary care at the end of active treatment. I think it's also really important because there will be people who are considered metavivors or who are living with active metastatic disease or incurable disease, whatever their particular diagnosis is. And in traditional survivorship models, many of those patients wouldn't have the opportunity to connect with survivorship until they are done with active treatment or they've achieved no evidence of disease on a scan. So kind of doing away with that old model and starting it from the time of diagnosis helps to create this relationship where you don't have to wait for that. And then you can kind of chip away at the aspects of survivorship over time, because if you only see a survivorship clinician or somebody who knows about what it's like to provide healthcare in a cancer-focused population, and you only see that person once a year, it's really overwhelming. There's a huge list of things to do. It's like drinking from a fire hose. And if you could slowly chip away at those things over time, every couple months with somebody who knows about survivorship medicine and onco-PCP care, then it's not so overwhelming. It's like manageable. You can do a couple little things at a time. So those are just some of the main things that I think about.
Thanks. And Donna, do you have anything to add about working on primary care and considering primary care from the date of diagnosis for the AYAs you work with?
I think, Sam was spot on in terms of, having that primary care, not waiting into survivorship, but really having that person along the journey makes such a difference for young adults in terms of their journey. Their cancer journey, and then the transition into survivorship, or for those patients that are continue treatment and they have needs, that they really need a PCP to be involved in their care, to be able to address those specific needs that young adults may have. And so it really is about thinking about that, incorporating that PCP care, that primary care early on in the cancer journey.
Just to tack on to that, I think you don't have to wait until you're no evidence of disease or the end of active treatment to pay attention to metabolic health, which is important sort of regardless. So like blood pressure, weight, glucose, cholesterol, things that impact your overall cardiovascular health and well-being, also mental and emotional health. And then really importantly, our vaccinations as well, especially in the blood cancer space. So the sooner that you can get people vaccinated for, vaccine preventable illness and can provide them that level of protection. A lot of times we want to get people vaccinated even before the onset of active treatment. So like as close to the time of diagnosis before they begin systemic treatment that will lower their immune system and increase risk of infections, then the better. And that's where longitudinal survivorship as well.
That's an important note. Abby and Alyssa, I'm going to ask you a couple questions about your own experience. Abby, did you have a primary care physician when you were diagnosed with cancer?
I did have a primary care physician. It was the same doctor that I had seen for years. A lot of my family also saw him. I'm from a small town. But my diagnosis, like a lot of young adults, it took a long time to get a diagnosis. I had a lump under the skin in my hand. I could feel it when I first went to him. He told me it was a cyst and not to worry about it. It continued to grow quickly. I went back, was still told it was a cyst, but that he would refer me to a hand surgeon. Went to the hand surgeon, had it removed, and because it was never any pathology done before the surgery, once I had a cancer diagnosis, I had to then have a second, much more extensive surgery to remove the footprint of the original surgery. So, yes, I had a primary care doctor, but like many young adults, I felt like if my diagnosis had been correct earlier, I probably would have had an easier time with treatment.
Alyssa, what was your relationship like with primary care after your blood cancer diagnosis?
Well, I did have a primary care prior to my leukemia diagnosis, but it didn't go well, and I didn't go back to him after I was diagnosed. I had seen him because I'd gone into a gastroenterologist and because of bloating, and found that my white blood cells were very low. And so she referred me back over to my primary care. We did blood tests every week, expecting that they would go back up if I just had an infection or an illness or something, and they weren't. But I also had other concerns that, I was training for a triathlon at the time. I was eating very healthy, exercising every day, and running and biking, and I was gaining weight rapidly. I mean, I think I'd gained 20 or 30 pounds in a very short period of time. And I was like, something's not right here. And I know something's not right. And he laughed at me. And I was so disappointed. And he said, if I had the magical cure for weight loss, I would be a millionaire. And that's what he said to me when I told him my concerns, and I'd already had low white blood cells. So I'm like, we already know something's going on. Something's not right. And you're laughing at me. And so once he referred me off to a hematologist, I just never went back.
And Tricia, both Abby and Alyssa's story is so common to what we hear in young adults. We know that young adults many times are diagnosed at an advanced stage just from delayed diagnosis. Unfortunately, at this age, cancer is not at the top of a differential list for many of the symptoms that young adults present with. And so young adults do, for many, the story begins with having to struggle to get to that diagnosis. And that struggle many times begins in primary care. And so, we spend a lot of time in our AYA program talking to our young adults about the importance of primary care and trying to find out where they are in terms of, do they have a relationship with a primary care provider? Is that someone that they feel that they can trust, that they feel that, that primary provider listens to them? And for some of the young adults that we see, they do very much feel, like they have an established relationship of trust, of open communication with that provider. And so they feel like, yes, I can identify someone on my healthcare team that I can go to with these needs, and that can be a part of that team to take care of this. And for some of them, we're starting at zero. And it's about helping them identify what are the systems that are in their community to be able to fill those needs. But it really is one of the big barriers that we see for young adults is, what has been their past experiences with primary care.
Thanks for sharing that. It actually leads into my next question of, how do you practically help someone who doesn't have a primary care physician find one as early as possible?
So one of the things that we do in our, we are a major cancer institution, and so we see people from all over the country. So it's finding out, do they live in a rural town? Do they live in a large metropolitan area? what are the health systems that are in place in those areas. We know of networks that provide onco PCPs, where there's a network maybe of primary cares that we've worked with in the past that feel confident in being able to take care of patients with this type of history. One of the things that I counsel patients on is I recommend that they seek physicians who are internal medicine versus family practice, just because they're more adept at being able to take care of some of these more complex issues that our patients may encounter. Not meaning, for some of our patients that live in rural communities, a family practitioner may be all that they have access to. And a family practitioner, if they feel comfortable taking care of these medical needs, definitely is capable of doing that and has the network of specialists to refer to if necessary as well. But that's sort of finding out, where are they living? What does their community look like? What's the infrastructure for them in their community in terms of access to primary care?
Thanks. And Sam, beyond what Donna just mentioned, what should patients be looking for in a primary care professional?
Yeah, I think there's just some great points. I think there are some family med trained people that do feel comfortable in this space, but it's got to be a really transparent conversation and ask. Even though it's very hard sometimes to interact this way with doctors and clinicians, it's okay to just interview a prospective clinician and say, are you comfortable taking care of patients with cancer? Have you heard about survivorship medicine or onco PCPs? Do you work closely with oncologists in case a question comes up? Is preventative care covered in this practice model that you participate in? And if you don't get a confident answer, like, oh yeah, I have experience with this, or I have a ton of patients, or then move on to the next person. Because I think that it's also very important to think about the personality or like the style of the clinician who's taking care of you. Onco PCP world, survivorship medicine, it's hard. A lot of us in the blood cancer survivorship space are medically complex. And even just taking a look at the MD Anderson survivorship guideline practice algorithms, you can look up your specific cancer type and it lays out all the things visually that you should have in survivorship based on the care that you've gone through, or even Children's Oncology Group guidelines. That's almost a 400-page document, that's broken down by subtype of therapy, and then what are the long-term toxicities that people need to monitor for. So it's very in-depth, it's time-consuming. So when you're seeking out a primary care clinician, even if they're not labeling themselves as an onco PCP, somebody who's detail-oriented, diligent, who doesn't seem to have an ego response or some type of angry or annoyed reaction when you say hey, I brought in this paper, or I'm not so sure about this, what do you think about that? Somebody where you feel like they'll really partner with you to sort of take care of your health in a very careful way going forward. I always say in my practice that I think about symptoms in survivorship in 3 different buckets. So is this cancer related? Is this a relapse, recurrence, or progression? Is this cancer treatment related? So the shortness of breath that you're having, could it be a heart issue after the chemo that you took or radiation near your heart? So is it cancer related? Is it cancer treatment related? Or is it unrelated? Because sometimes people who've had cancer can get a cold and has nothing to do with anything. So those 3 buckets, and just being very transparent about partnering with your clinician on working through those problems or those health concerns, so that you don't have to sort of silently shoulder the fear by yourself and wonder whether or not they're going to take you seriously enough, or if they're going to overreact or underreact. You work together as a team to try and address, could it be one of these 3 pathways? And that's not the personality of everyone. So I think really being honest about those discussions and that intuition that you feel when you're with that person, do they make you feel cringy or make you feel bad for asking questions? Run for the door and get the next one.
Good advice. So you mentioned OncoPCP several times. What is that?
Yes, I'm still learning, but um, I sort of got in this space and started learning about what OncoPCPs are by really understanding that National Cancer Institute defines survivorship as anybody living after a cancer diagnosis through the balance of life. But historically, it hasn't really been delivered that way. Survivorship care has tended to focus on like some diagnoses more than others. And it really focuses on care after remission is achieved, after the end of active treatment. And I just felt so strongly after my own experience as a patient, and then really tons of conversations that I had with people in all different kinds of practice models across the country and how they're doing survivorship care, where I thought, gosh, like I don't think it should be delivered that way. Like, why aren't we delivering it in alignment with how it's defined? Like, why isn't there a practice care model that delivers survivorship care longitudinally from the time of diagnosis? And then lo and behold, there is. They're called OncoPCPs. Kevin Effinger is a clinician, I believe, who's done a lot of work in this space and defining what this practice style is. But we're still a very small population of clinicians who label ourselves this way. There's still not yet like official OncoPCP trainings, like fellowship programs. There's starting to be some core competencies, so it's really just early days of finding, people who might label themselves as that. So you could say onco PCP or survivorship clinician. Those are all kind of terms that are used to look for somebody who practices that way.
Thank you. Donna, what if insurance doesn't cover a primary care physician that the patient has access to?
So that is a barrier that some patients encounter, just the finances. We know that cancer diagnosis in itself comes with, tons of financial toxicity for patients and survivors. And so, working with the social worker on our team, just to be able to inform what are the resources that are available through different avenues, in terms of being able to connect patients with care. What are the local county or government programs that that patients might be able to qualify for, and then thinking about what if any are there fee for service encounters that they may be able to have. Unfortunately for patients who fall in that gap, they end up having to piecemeal so much of that. And it's really unfortunate. Of course, with the Affordable Care Act, and being able to extend insurance coverage for many young adults to stay on their parents' insurance up to the 26, much of that gap has been covered. Many of those young adults prior to the Affordable Care Act really didn't have anything. And, this was a very common occurrence, a very frequent occurrence where, these patients had no coverage, where there was no safety net at all. And so now, being able to access that coverage either through the marketplace or through some other avenue, whether that be, extending your coverage through your parents, whether that's providing care, extending coverage through COBRA plans, if you're transitioning, from a job. And so that's really where working with a social worker who has worked with AYA in college is really helpful, because they're so well versed in that area in terms of, what are the different options available for these patients. It's not one set option for every patient. So what are the things that are available? What's the life circumstance for this patient? And, how can we help them to continue to receive that care that they need? It really becomes a crucial part of that journey. And so really, it's part of being part of this holistic team that social workers always also make part of. That's really important.
Thank you. To switch gears a little bit, why does it take so long to get a primary care appointment, and does it matter? That's to Donna again.
Yes, it does often take many weeks to be able to get in to see a primary care, and for patients, I think Sam's sort of image of the three buckets. Is this cancer related? Is this cancer treatment related, or is this not related? And for many of our patients, for many patients who have had a cancer diagnosis, even aches or pains, are scary. And they can be very anxiety provoking because for many, it doesn't matter how long off therapy or how close to being on therapy a patient might be, those aches or pains really really will make them anxious. Is this because my cancer has returned? Is this some early symptom that something's going on with my body? And so, being able to get into your PCP, is really important. And so I think this is one of those times where when you have a designated PCP. However, what's the sort of, it's looking at the PCP, I think what Sam talked about, interviewing the PCP, like do they feel comfortable being able to to answer these questions? Are they detail oriented? How do they feel about you bringing them information, looking at these guidelines, like how comfortable do they feel in that sort of relationship? But also is it just them? And what kind of supports do they have within their practice? Are they part of a larger practice? Are they part of a health system? It might be that you may not be able to get in to see them that day on the day that you're experiencing a need, but you might be able to get into the same day sick clinic, and then you're able to follow up with them because you've been able to go in, be assessed. Have some peace of mind, have, a medical professional be able to assess your symptoms and begin, if there's a diagnostic workup that needs to start at that point, be able to start that journey and then, involve that PCP. And so I think while, yes, you want to know who the sort of is the quarterback of your team, it's also what are the other pieces that are there to be able to support you and have access.
I think that's an important point, that doesn't have to be just the resources at one location. There may be other opportunities close to you that you can utilize services for to meet the need more immediately. I appreciate that. Abby or Alyssa, did you all struggle to get primary care appointments or have any barriers to getting primary care?
Yeah, I ended up having some issues. So it took me 7 years, I think, to finally feel like, yes, I can move on from my oncologist as my default primary and finally go into look for a primary care. And so I told him at my annual visit that, hey, I'd like to get into primary care. And so he referred me to somebody within the hospital system. And that was a 4-month wait until I was able to get in. But I was like, listen, nothing's really wrong. I just want to get established. So then hopefully once I'm established, I can go in if I have any issues, any illness, I sprained my ankle, whatever, I can get in within a few days. And so went and did that. Had a wonderful experience. And so she stayed with me for 2 hours. It was great. And then I didn't really have a big need to go back for quite a while. And then all of a sudden I get an email from my insurance company several months later, and they had assigned me a primary. And I was like, that's weird, because Oregon has a new law now where you get assigned, you have to have a primary. Everybody has to have one. And so I called up my insurance company and I said, hey, I already have a primary. I just got established with somebody a few months ago. And he said, she's not in network for you. And I'm like, what do you mean she's not in network for me? She's at my hospital system. And he said, I'm sorry. And so he's like, I'll send you a list of all the people in network. Not a single person in my hospital system, in primary care, internal medicine, or family medicine, any of it, is in network for me. And that was really hard. I feel like it took me so long to be able to even think about going to primary care. And I did it a lot because of Sam, and she'd done a How Do I video, and I was like, I can do this. And so it was really disappointing. I think I cried the rest of the day. And so now I still haven't really looked. So I really need to look again and start this process all over again. So it's really discouraging. And so, I'm hoping it will get better, but I was so enthused after seeing this primary because she was wonderful. And so it's disappointing.
That sounds incredibly frustrating, and I'm so sorry that that's been your experience, and I do hope it gets resolved soon and that you do get to go back to your preferred physician. I think that's important. As Sam and Donna mentioned, that trust is really key, so I hope that happens for you. Abby, do you have anything to add?
Yeah, I mean, going off of echoing what everyone else has already said, I mean, that trust is so important. And when I decided to look for a new primary care physician, my oncologist I'd had a really great relationship with, and I knew I wanted someone with a similar bedside manner. I also knew that I probably would feel more comfortable with a woman. So that was, just one of my things to kind of help me narrow down the list to try to find someone. And that first step of getting established is hard, and you do have to wait. But I do have a primary care doctor now that I like. She is always willing to work with me. She's also willing to say when she doesn't know something and to refer me out. I had a few years ago, I had questions about if treatment had impacted my fertility or if it, could cause any issues if I were to become pregnant. And she just said, that's out of my expertise, but I will refer you to a maternal fetal medicine specialist. And so I just really appreciated that that's how she approached it. So that definitely built that trust. And I also just want to give a shout out to the Affordable Care Act. I was 22 when I was diagnosed. And I was in my final semester of college. And so I stayed on my dad's insurance. And if I wasn't able to do that, I don't know what I would have done. And of course, after graduating, I was still in the midst of treatment. So finding a job immediately also wasn't an option. So yeah, I just want to give a quick shout out to that those laws are really important and they really do protect and help young adults.
Thanks. Yeah, it's that coverage is key to be able to pay and not have extreme catastrophic out-of-pocket costs for medical care. Sam, what is primary care going to provide that's different from oncology care?
Yeah. Well, one thing I was just thinking of with Abby, and it's really come up for a lot of my patients recently, and I know that I experienced it as a patient, is really this in the AYA space too, is this idea of like the prolonged graduated return to work. So many people, especially young people, prime of their lives, and they're in some kind of work, like they want to work, they want to return to some kind of work afterward, but the ability to work has changed. Like obviously you're going to be different after 2 years of treatment or however long it took than you were before this happened. And I think sometimes the system kind of treats people like that when you get diagnosed, you hit a pause button, and then when you're done, at some point you hit the unpause button and resume. And that's just not the lived experience. It's not the reality of the situation. Many people carry these invisible scars, or just they're differently able than before they were diagnosed. So like for me, my issue as a clinician, as a doctor, where my job is very cognitively intense, I had the worst chemo brain. It took about a year for it to fully clear up. There were points in that first year where I felt like I could do some work, but I had to really work with my healthcare system and say, I feel like I could sign prescriptions that are simple. I feel like I could sign vaccination orders, but in terms of overall like life and death decisions, I'm not quite there yet. Like I will get there, but I don't know how long this is going to take. Like it took this very long kind of period of time to recover and rehabilitate from the toxicity of my treatment. And fortunately, I'm doing well now, but so the prolonged return to work is a place where a PCP can really be helpful in support with the oncologist. If there are ongoing issues that need accommodations, whether those are like physical accommodations, reaching for things, carrying certain levels of, of weight at work, or even just helping to come up with a set of accommodations, like needing more frequent breaks, more time to complete tasks, things that sort of acknowledge what your body's been through and yet say, like, you're not broken. You can still work. Like your healthcare requirements, how you live in the world, how you show up to your job, it's different than before, but you still have something valuable and meaningful to offer. So I think helping to support overall functionality and connection in your life, and a really good PCP and survivorship should also provide like trauma informed care. This is very traumatic, and I'm saying this like I'm due for a checkup and I'm going in like the next week or two. I am scared. Like, I do this work every day and I'm still scared to go to the doctor. I'm scared to get my blood work. Um, it if they can't get a vein the first time, like tears are streaming down my face. And I used to have a really high pain threshold, but it just brings me back. And so I think anybody who does this, who's going to work with you, should really know that it's trauma informed care, that going through blood cancer or many different diagnoses where there may have been surgery involved or really intensive treatments, that even when the outcome is good and you have the desired outcome, like your no evidence of disease or your disease is stable for a really long time and you're thinking about moving forward in life, there still needs to be an acknowledgement that yes, you just had this like life altering thing that happened. And of course that's going to impact how you are. So somebody that addresses your sleep, your sort of, emotional status, and overall like metabolic health and things like that, and your family. I think that a lot of times, caring for the people around the person, that just kind of gets relegated to social work or these other specialties. And I think inviting in social workers, and other people on the team can be really helpful. But sometimes it's me who says, oh, who's at home? Oh, you have kids? Like, do you know about Camp Kesem? Or asking every single blood cancer patient who walks into my clinic, like, have you heard of Leukemia Lymphoma Society? Are you connected with them? Let me take the time and put in a referral, because they do so many things that we just can't possibly do in my healthcare system where I work. And so just like bridging that gap and making that connection to all the supportive care space. Because I think a lot of times patients may not know. They might think it's more just about peer support or talking about their feelings. But there's a lot of practical things that organizations like LLS and other supportive care organizations provide, that go beyond what the healthcare system can provide.
Thank you so much. And I actually want to hear the answer to the next question from a survivorship perspective. So I'm going to ask each of you, but then I want to follow up with Donna and Sam from your professional perspective as well on this. Abby and Elissa, what do oncologists need to think about when transitioning their patients to primary care from your own experience? We can start with Abby.
That is such a good question. I think that the acknowledging that anxiety that's probably there, if they happen to have suggestions for primary care, that is also great. Providing a survivorship plan or documentation, or telling you how to access those things on your portal, so or they helping you share your medical records once you do have a primary care doctor. My oncologist was actually really great. She would email with my primary care doctor at first. Like if I'd have a scan, she'd send just like a personal email to say, here's the results. So, I think that those are the things I would say.
Speaks to how important that oncology and primary care collaboration is. Elissa, do you have anything you want to add?
Yeah, I mean that's something that I would say as well, is having that ability to communicate with each other. I think is really important, and that is why I wanted to stay within my hospital system, so that they could all be on the same MyChart and be able my oncologist would be able to see what's going on with me, and vice versa. If there was anything to happen as far as cancer was concerned or anything like that, insurance would be obviously my next suggestion is to, when referring out, to make sure that, they do take your insurance, and then for the patient to check as well. That is something that I didn't even think about, because like, this is my hospital. I've been with them for, almost 9 years. I mean, why would they not be on my insurance? And so, I think that would be something that would be really important. And also, I think, again, like, recognizing that the whole situation that we've been through is traumatic and continues to be traumatic on some level. And so I think recognizing that, and, like, for me, it was really hard for me to get to a point where I felt like I could move away from my oncologist, because this is somebody that I really trusted, and I still trust, obviously. But it was really, really hard. And so I think to recognize that it is hard for patients to kind of move away and move into seeing somebody else that would still be really good for you, but also saying that, we can all communicate together. We're all part of your treatment team at the end of the day. And so I think those couple of things are important.
Yeah, several of you have mentioned this reliance on oncology care as primary care beyond when it's appropriate to do so, that some of these really supports and assessments and treatment needs to happen from a primary care perspective. But it is very hard to let go of, like Sam was saying, she's scared of going in to get blood work. What if it says this? Now you have to go back to your oncologist for this. So it can be very challenging and confusing, I think, for patients. Sam, do you want to add anything from either your survivorship perspective or what we need to do to train oncologists?
Well, I think, a couple of things I would say is that to train oncologists, I think how you have that conversation with patients, if having it really delicately, like, hey, I'll continue to be here if your primary care, um, has any questions, or if they want to call me, even just to have the direct sign out of things. Or I'm happy to provide a note of, here's the special way to kind of think about you based on what you've had. That open line of communication is really important. And then as a patient, to just feel confident that you might know more about what you need. You probably know more about what you need than your primary care clinician. Like, even in my situation, my providers are like caring and colleagues that I have worked with before. But like, I had a severe bladder injury during my stem cell mobilization. I had hemorrhagic cystitis from cyclophosphamide. And so I'm like trying to get my big girl pants on, because I want to ask for a urology referral. And I just know that I need that based on the, and I don't think I'll get any pushback about that. I think I'm totally just like all in my head about it, about like going in there with an agenda to like these specific things that I want to ask for. But I do feel some level of, oh my God, are they going to be annoyed with me? I'm telling them how to do their job. So I'm just trying to empower the patients who are listening to this, even though I'm being a complete hypocrite right now, because I also feel afraid. But that, um, if you've read those guidelines, if you've read about long-term complications from some of the therapies that you took, that you might have a better idea of what you need, and it's okay to bring in a list. You might want to send in the list ahead of time and be like, look, I know appointment times are super slow. I'm coming in there with a list of like very specific things that I'm hoping to leave there with, just to give them a little bit of time to digest that before the visit. If there's a way to send it in over secure messaging or email, so that, they're not, you might spend 5 minutes of your visit just kind of shooting the breeze, and then, you've only have 5 more minutes left for them to put in lab orders and referrals and things that you want. So if you have an agenda of what you're going in for, and many survivors do and should, because, bone density scans and all the like ancillary things that a lot of people are not even thinking about it because it just seems so much lower on the priority list compared to wondering about, ongoing remission or relapse or complications, but just what is the health maintenance of somebody who's been through kind of what we've been through. So eliciting the list and sending the agenda ahead of time can be really helpful. And I plan to do that.
Great. Yeah, I think it goes back to what Abby was saying about a survivorship care plan, that it doesn't have to be a formal thing. It can be an answer to your questions, but it can be helpful information to figure out how you navigate what's next. On the flip side, Donna, what do primary care professionals need to know about, and you work specifically with adolescents and young adults, what to know about them transitioning from oncology care to primary care? What do the primary care physicians need to know?
I think they need to understand that these patients are very complex. They have complex medical histories, and they have experience within the medical system. And so they're not your run-of-the-mill patient that's coming in that maybe not be as versed in how to navigate a healthcare system, or how to juggle multiple specialists or multiple medical needs. I mean, young adults come in, have been in therapy and treatment, 1-2 years, have seen, have a main oncologist, but have maybe seen a radiation oncologist, and maybe have seen, the onconephrologist, or they've been seen in oncocardiology. And so they've had, this is not, that you have an experienced patient before you. So bring your A game. And so I think sometimes for some providers that can be a little bit unnerving. And so knowing that ahead of time, that you are having that communication. And I think I'll go back to the previous question, how can oncologists help to transition patients? I think it's, having that conversation with the patient in terms of like, this is why this transition to survivorship primary care is important. This is what can be offered and needs to continue to be offered to meet your needs. And this person is another person that we're adding to our team in caring for you. And of course, if you can have a system in which your oncologist can reach out to to the primary care that they're referring you to, that's wonderful. And they can say, hey, I'm sending you Sam, and this is Sam's history, and this is some of the, whether that be electronically or over by the phone, to say, this is some of the complications that she's experienced in care. And give some of that social background, I think is very important as well. Then that makes that transition smoother. That's not always going to be the case, obviously, but being able to have that, incorporating them in care. And I think for many patients, transitions are difficult, whether it be from, it's from newly diagnosed to on treatment. That's a difficult transition. From completion of treatment to then, you go to surveillance. That's a difficult time period. And then now this is a different transition. And so recognizing that, this is another transition, and that each of those transitions does bring up its own feelings and emotions about that, about stepping into that next stage. And, I talk a lot to patients about, it is normal and natural to feel anxious about, do I feel like I can step in? Am I prepared to be able to step into this next stage? And, I've learned how to live in the previous stage, and now I'm advancing, and now I need to learn sort of what are my supports. I need to learn my surroundings in this next stage, and how do I thrive in this next stage? And, what are the support systems that I need? And being able to advocate for yourself, and advocate with the support systems that, you've previously had to be able to meet the needs in this new transition period. It's really not about moving from one transition to another, but it's about creating links between those different stages of transition. And you can bring so much of that with you. And, I think that's the mark of great oncology care and great survivorship care, is that these links are created throughout the stages of care. That really, form a net to help support patients, and so that they can kind of hold on to those things as they, continue to progress in their life, and continue to thrive, because that's what we want for our patients.
Yeah, you highlight how complex navigating all of this from the date of diagnosis and beyond is, and how bridge building is so key to making survivorship successful. So I really appreciate that insight. So we've talked a lot about self-advocacy. So for our final note, let's talk a little bit more about broader advocacy. I know our Office of Public Policy is focusing some broader advocacy efforts on insurance appeals and denials, and the increased likelihood of denial, prior authorization, or denial of a claim post-service is for young adults because of their age. It's not seen as a necessity, but we know young adults with cancer face more necessity for some of that follow-up care than others. So I know they're working on that, and I know they're working on fertility preservation service laws across the country. What other, and we can start with Sam, what other broader advocacy or public policy changes are needed to support cancer survivors as they transition from oncology to primary care?
Yeah, I think coverage of survivorship care and a lot of the different tests, and also just updating even ICD codes for certain diagnoses that are frequently managed in survivorship. So, for example, something that I see all the time in my clinic is treatment-related cognitive impairment, or chemo-related cognitive impairment, or chemo brain. It's how it's more commonly known. And that is something that, as I described in my own case, took a really long time to heal. A lot of different tests that need to be done to rule out root causes of ongoing sort of difficulty with thinking and executive functioning, like labs. And so things that need to be medically assessed, there's a certain process for evaluating it and helping somebody to heal from it. Takes a while, but there's no ICD code for it. There's no ICD code for related cognitive impairment. And yet it's something that clinicians like myself spend a lot of time helping people shepherd through the medical system and the recovery process. And so if we don't even have an ICD code that somebody can bill for the care that they're providing, there's going to be problems with that care being reimbursed and then valued financially in a way that incentivizes people to do the care. So that's just one small example, but there are a lot of others.
Thank you all so much for joining me today on this important discussion about transitioning from oncology to primary care. LLS has several resources for survivorship and for young adults specifically, and those will be at the bottom of the recording, and people can access them there. Thank you.